Good morning, or good afternoon, or good evening, wherever you may be. I'm Dr. John McGahan. I'm from the University of California, Davis Medical School, which is located in the fabulous city of Sacramento, California. I'm going to talk to you about what everybody should know about examination of the fetal heart with ultrasound. In speaking about some of the guidelines and the certain CPT codes that are being used for examination of the fetal heart, probably the two most common are what is called a 76805 and a 76811. 76811 is which most people do for what is called a level 1 or sometimes a level 2 ultrasound, and what we do there is look at the four chambers as well as the outflow tracts, and a 76816 is a follow-up. So this is also the different guidelines. So ACR, AIUM, ACOG, they all have very similar guidelines for practice parameters for obstetrical ultrasound, including looking at the four-chamber view of the heart, looking at the left and the right ventricular outflow tract. However, there was a task force formed, and they had the results of the task force published in the Journal of Ultrasound and Medicine in 2014. They called themselves the 76811 Task Force. What they basically said is this exam that we looked at previously, which was the four-chamber view of the heart plus the outflow tracts, they expanded, and they thought it should be expanded. Now, none of this has been officially adopted by the CPT codes, but this is what the task force recommended. What they called as a basic would be what previously would be included as the 76811, not the expanded 76811. So they included obviously the four-chamber view of the heart and the left and the right ventricular outflow tracts. So basic exam would include, as shown here, a four-chamber view of the heart, as well as outflow tracts. One thing that I will talk about is when we do outflow tracts, I always like to do them in real time. So in real time, I can see the relationship of the RVOT and the LVOTs to make sure that they crisscross one another. Well, they've expanded that to include not only those views, but also a view of the aortic arch, what they call as a bicaval view called the superior and inferior vena cava view, a three-vessel view of the heart plus a three-vessel and tracheal view, view of the lungs, integrity of the diaphragm, and evaluating the ribs. If we look at some of these detailed views, on the left is what is called an aortic arch view. So this is the candy cane view looking at the aortic arch, and through there you can see branching of the vessels towards the head. The other view on the right is taken as a bicaval view. Superiorly we have the SVC, and inferiorly we have the IVC, and this is called a bicaval view in which we look at both. So these are two additional views that we will not talk a lot about these, but these are two additional views that have been added. And finally, the view that I will detail is the three-vessel view. Currently, and we've been doing the three-vessel view at our institution and our lab for the last 10 years or more, and we find it very helpful if in fact we can't see the normal outflow tracts. We do this view in real time to show the relationship of the aorta and the pulmonary artery to either the right and or the left ventricle. So the detailed view would include these views. In here we'd also be able to see the trachea, and if you look carefully, and sometimes you can see the trachea bifurcating into the right and the left mainstem bronchus. In this view you see the pulmonary artery, which is over to one side, then the aorta always centrally, and the SVC over to the right. We can also look at this higher, in which we can see sort of a V-shaped sign in which the pulmonary artery and the aorta come together, where the pulmonary artery starts to form the ductus through this region. Well, to start, we're going to start with the four-chamber view of the heart. In this, we basically publish something called the PASS. So I'm going to actually put that down smaller, and we're going to look at P for position, that is situs, A for the axis of the heart, then S for the size of the heart and also the size and thickness of the ventricles, and then S for is that septum intact or not. So these are the four things that we're going to look at. So in this case, the stomach is midline. We see the portal vein midline. So what is the diagnosis here? Is it a situs inversus, situs solitus, situs ambiguus, or I just don't know? So if we look here, this is heterotaxy. So this is called situs ambiguus. And if you look here on this chart, this can be due to polysplenia or asplenia. If you have true situs solitus, whatever the background is for cardiac malformations, whether it's 2%, 3%, that's our cardiac malformation rate. It increases with true situs inversus totalis, in which everything is completely inverse, but not to the same degree as when you have heterotaxia. When you have heterotaxia, you have markedly increased rate of cardiac anomalies. And in this case, there was a large AV canal, as you can see here. And so these are different views of the AV canal in this case of heterotaxia. So we start looking at the situs. Next, we look at the axis. Again, we start again by looking first at the situs. So we see that the stomach is on the left. Apex of the heart is also on the left. From there, we look at the two complete ribs and we try to scan exactly where the ribs are. We can go ahead and we will show you, or I'll show you what the normal axis here, usually about 45 degrees. So we draw a line from anterior to posterior, so from the spine anteriorly to the sternum, and then draw another line down the interventricular septum. That should be about 45 degrees. It can be too big or it can be too small. So if you have a cardiac axis greater than 45 degrees, these are the potential etiologies. This is a case of Ebstein's abnormality, in which you can see the ultrasound on the left and the diagram on the right, and then we have a MRI, but you can see here there's enlargement of the right atrium usually, so you have a malposition tricuspid valve usually, and in this case you can see the axis is abnormal. It's closer to 90 degrees and in fact 45 degrees. Here we have a CPAM, and you can see in this case the heart axis isn't too bad, but certainly it's above 45 degrees, but you can see that the heart is displaced into the left hemithorax by this large mass on the right side. Here's an interesting case, and you look here, the axis is about 0. And there's something very interesting on this case that I don't know if you can observe, but if you look carefully, such as we see here, you see a little bump on this 3D image in which there is a bump seen anteriorly. And then if you look here, there is an ectopic cordis. So in this case, the axis was about 90 degrees, or about 0 degrees, excuse me. Third, we look at the size of the heart, the ventricles, and we're going to go through this. So in general, the cardiac circumference to the chest circumference should be less than 0.5. I use the rules of 3, or I subjectively just look at that. Rules of 3, we look at the heart. We should be able to place 2 other hearts. It's actually about maybe 2.8 hearts in there into the thorax. In this case, there's obviously a huge heart. If you look very carefully, there's also a pleural effusion. But this case is due to a fetal tachycardia, and so there's basically failure of this heart, and we get a very large heart, so it doesn't follow that rules of 3. And these are the different etiologies, so I show you the arrhythmias. You can get it from cardiac failure, extrinsic such as Ebstein's, and then a cardiomyopathy. On the other hand, look at this heart. This heart is pretty small. So if you look there, you have rules of 6 here instead of rules of 3. So that heart is compressed. So is it compressed by bilateral sequestration, CPAM, CCAM, etc.? And what this is congenital high airway obstruction, which there's obstruction of the tracheal or bronchial tree here, and you get very echogenic lungs that in fact ended up compressing the heart and making for a very small heart. Looking at the ventricular size, in general it's about a 1-to-1 ratio. If we get it and we look and we're right on, right ventricle may be a 1.1 to 1 in terms of the left ventricle, but in general the size is pretty close. Look at this case here in which there's tricuspid atresia. In real time you can see there's hardly any right ventricle whatsoever. Very echogenic valve here. There's virtually no flow getting into there, and usually these are associated with some sort of VSD. This case is not. We'll show a case that is. Here's another case. Looks very similar, but you can see here blood flow goes from the right side over to the left side, and very little gets through here. But if you look here, there's a little bit of flow in through that tricuspid valve into the right ventricle. In this case, right ventricle is still small and very echogenic, but it is larger than the case I just showed you. Finally, you can have hypoplastic left heart, so you can have asymmetry of the heart where the right ventricle is much larger than the left ventricle, and you can see here the discrepancy here. In addition, the aorta is often affected, especially the ascending aorta in these cases. Ventricular thickness, well, you can have cardiac tumors. Thrombus would be rare. Endocardial fibroelastosis is rare but not uncommon. Here's a case that actually has both, and if you look here, you can see there is a cardiac rhabdomyoma. In addition to that cardiac rhabdomyoma, there's the cardiac rhabdomyoma, there's cardiac fibroelastosis. So that heart muscle becomes thickened because it's trying to pump against something and it's having a very, very tough time. So it basically hypertrophies in this case. These cardiac rhabdomyomas can be small, they can be multiple, or in this case, they can be very large. If they're very large, the prognosis is poor. If they're very small, actually the prognosis is very good. But they're often associated with tuberous sclerosis. Finally, the septum. Is that intact or not? And that's sort of the fourth area. This is the toughest area. So if you look at all cardiac anomalies, this is the area that is most commonly missed, are VSDs. And if you look here, you can see maybe a little VSD. You're not sure where the arrow is. When we go ahead and we put color flow, and it very nicely shows us that, in fact, yes, there is a small VSD. Certainly, in cases such as this, a tricuspid atresia, you can see that the right ventricle and the left ventricle are discrepant in size. There is tricuspid atresia, but you look and you wonder, is there just a little hole in the heart? You go ahead, you do color flow, and you can see, yes, there is a fairly high VSD. So there's flow from the left ventricle into the right ventricle, which actually preserves flow. So it actually helps preserve some of the right ventricle as well. Here's a real time of that, and now you can see that in real time where that small VSD, you can see there is tricuspid atresia, and you can see normal motion of the mitral valve on the left side. Now, if there's a larger defect, you would think it would be easy. It isn't always easy. Remember that, in fact, that the tricuspid valve is closer to the apex, slightly offset compared to the mitral valve, as you see on the left of that example I showed you of a cardiac arrhythmia or tachycardia. On the example on the right, if you look carefully here, it almost makes a T, and there is a large VSD, but you have to look exactly. That's why you have to get a real-time clip. You cannot take one moment in time or you will get fooled, and I've seen people fooled with this. So you take another moment in time, and in fact you see that T configuration of the two valves with the curved arrow. You see here there is a very large endocardial cushion defect where there's a defect both in the atria as well as the high in the ventricular septum. Sometimes these defects can be even larger, and they're more easy to recognize than this one, but you can see how subtle it could be in this case. Also, often these little end of the ventricular septum where there is a VSD will appear bulbous or almost light bulb in appearance. Here's a complete AV canal, and you can see here between opening of the valves and closing of the valves, get that complete T appearance, and you can see there's no ventricular atrial septum here, a fairly large AV canal. Here's another complete AV canal, and you can see sort of this bulbous appearance. Some people say it's a light bulb appearance, but you can see where the ventricular septum ends when there is a large ventricular septal defect or an AV canal. You can see it very nicely here, this large AV canal in real time. You can watch closely as the two valves come together, almost form that T configuration where they actually touch together. Well, remember, the hardest job is those of you that do a screening job. So if you have to do the 4-chamber view of the heart, that is the toughest job. So in addition, basically the AIUM says now it's recommended that you do a right and a left ventricular outflow tract. And there may be other anomalies that you can detect when in fact you do a outflow tract views. Tetralogy of Fallot, some of the T's you can see, transposition. So a lot of these sort of things you can see when you do outflow tract views. Here's very nice outflow tract views, but they're not in real time, and I always emphasize obtaining things in real time. So they look like they crisscross here, but it's nice to have real time. So again, you want to go ahead and you see the RVOT, and then you want to see the LVOT, RVOT coming straight down, LVOT that comes more parallel to the long axis here. And so this is a case of a normal, but things in real time. So you got to see the RVOT, LVOT in real time. And here's such an example where it could be missed. So this was called left ventricular outflow tract. This was called the right ventricular outflow tract. Guess what? This was detransposition. No real-time images at all. And the worst thing in this case, there was no VSD. So this is all a ductal-dependent defect. So if that ductus ever closes after birth, there's no way for blood to get shunted from right to left. So this is very difficult. This example shows you, even though the sonographer thought this was normal, documented the RVOT, documented the LVOT, did not do it in real time. So in this relationship was more parallel than perpendicular. Here's a case of transposition of the great arteries. And the one thing you're going to notice here, this left ventricular outflow tract goes back to the ductus, but it bifurcates. Well, there should be no reason why the aorta bifurcates and forms and basically fills the left pulmonary artery. You also know the RVOT, LVOT tend to be more parallel. And we call this the baby bird's beak image. So if you see something coming out of the left ventricle that bifurcates, looks like this, that isn't a good sign. That means whatever is coming out is bifurcating. It probably cannot be the aorta. Here it is in real time. The RVOT and LVOT are very close together, and you can see something coming out of the LVOT that does bifurcate. That's the pulmonary artery. Again, real-time images are important. Now, this 3-vessel view, it has 5 views. It's originally described by Yeagle in 2001. We've been doing this view since about 2003 or 2004. And basically, if we can't get the normal outflow tracts, we always do this. So again, you would just start at the bottom for sinus, 4-chamber view of the heart. Then you bring your transducer up, and I do it in real time to take a look at the more superior portion of the heart. This is what it should look like. Pulmonary artery usually can bifurcate be the larger structure over on the left side, then aorta, then SVC over here on the right side. And usually you can see this bifurcate. Often you'll see the pulmonary artery, as I show you, come towards the descending aorta in a ductal view, and then right here you're going to see the aorta. These two often come together as they go into the descending aorta. Another view of this, and you can see back here sort of the ductus view, the pulmonary artery coming back. You can see the trachea, and you can actually see the trachea bifurcate. That I'll show you in some real-time images. So when we look at that three-vessel view, number one, look for the crisscross, and then look for the number of vessels, the alignment, the size, relationship to the trachea, etc., etc. So a normal relationship, again, should be crisscross. I'm going to show you a couple real-time images. They each show you something different. So in the first image, you can actually see the crisscross with the aorta coming over from the left side to the middle, and then you can see the pulmonary artery bifurcating a little bit, and it also will come down here to the descending aorta. Here's another view that shows you a little bit different, where the two vessels come together, and whoever did this did a great job, because they first showed us the stomach, showed us the LVOT and the RVOT and the apex pointing over to the left. Then as they come up from there, you can see in real time the RVOT goes down to the region of the ductus, and then you have the LVOT. If you look carefully, just adjacent to the aorta, you can see a little teeny structure, and that little teeny structure right there is going to be the trachea, and the trachea you can actually see bifurcate in this view. Again, real time is really what I would like to emphasize. So I'm going to look now, and my final portion is abnormal three-vessel view. Either aorta is greater than the pulmonary artery greater than the aorta, if they're parallel, two vessels or four vessels. Here's normal. Here's a case lent to me by Dr. Roy Philly. What is the diagnosis here? So the pulmonary artery is much smaller than the aorta. We would have this in Tetralogy of Fallot. So we see a very small pulmonary artery, a larger aorta, because the aorta is overriding. And if you look at this image, they match up perfectly. So if you look at the aorta size here, pulmonary artery, it's just absolutely perfect here. So this is a great example of Tetralogy of Fallot. Here's another example of Tetralogy of Fallot, in which I have aorta, SVC, and a very small little twig coming off the pulmonary artery. So again, there's discrepancy in the size with, in this case, the aorta greater than the pulmonary artery. Well, next, pulmonary artery greater than the aorta. So you can have a left ventricular outflow abnormality, such as in this case, we have double outlet of the right ventricle, normal on the left side. Pulmonary artery is much larger than the aorta in this case, and you had aortic atresia in this case. Another interesting case was the pulmonary artery is much bigger than it normally would. So you can compare that to the descending aorta. Certainly it's much larger. So this is a different sort of case, and this is a case of pulmonic stenosis. So if you had pulmonic stenosis, you would get post-stenotic dilatation. You can see here in this image vessels crisscrossing, but you see a very large or very dilated pulmonary artery. So pulmonic stenosis would be another example where the PA would be greater than the aorta. Parallel. So again, TGA. So you end up here, and you can see transposition in this case, in which the two vessels are parallel. So the LV gives off to the pulmonary artery, and the RA gives off to the aorta. And you can see they're not crisscrossing, they're parallel, as we see in this example. Finally, if in fact the aorta is much greater than the pulmonary artery, such as in this case of severe Tetralogy of Fallot, in which it was almost a truncus, but there was a little bit of a pulmonary artery at top. The pulmonary artery is very, very small. You see the aorta and the SVC in this case. Then in this case where the pulmonary artery is much greater than the aorta, and this is a case of a severe hypoplastic left heart, we virtually have no ascending aorta. And this can be very difficult if they want to do any surgical repair, because there's no ascending aorta in which anybody can tie into. Finally, 4 vessels, you can have a duplicated SVC. So this is my example of a duplicated SVC with other cardiac disease in which there's a duplicated SVC. You can see that here in this diagram as well. So again, hardest job is deciding, is this scan good or not? After that, then a referral is made. And we start just from the 4 chambers. Yes, we start from the simplest. If you do that, you pick up 65 to 70% of all major cardiac defects. Then you add to see if things crisscross. If you add that, you add another 20 cents or 20% worth, you're up to 85%. 3-vessel view can add a little bit more, especially if you don't see that crisscross. Those are the real things that I think you got to get, is those first 3 things. Aortic arch views, you can do that, or ductal arch, and then you can try that bicaval view. So again, in summary, the 3-vessel view, axial plane, you have to see that in real time. You want to see the size of the vessels, the location of the vessels, with the pulmonary artery slightly larger than the aorta and bigger than the SVC, and then see that relationship of the vessels to each other. So I hope you enjoy this update, or latest update, of how to look at the fetal heart, starting first with the 4-chamber view of the heart, proceeding to the outflow tracts, and then to some of these newer views. So thank you very much, and I hope you've enjoyed this.